patient once came in ophthalmology outpatient department during my residency with complaints of diminution of vision in eye associated with pain, redness, floaters, and periorbital swelling. After taking her vision, I took the patient for examination, during which I was amazed at what I saw. I saw a yellow ball playing hide and seek with the light. To this, the exhilarated me shouted, "Sir, I can see a yellow ball moving in the vitreous cavity." To which my sir started, and I quote, "Ocular cysticercosis is a preventable cause of blindness caused by larval form of Taenia solium called Cysticercus cellulosae. Humans usually ingest the egg form of the cystole through contaminated food and water." After some meeting about the symptoms and other ocular manifestations of ocular cysticercosis, he said,
Cysticercosis involving the posterior segment of eye usually involves the vitreous cavity or subretinal space. It may be associated with variable RPE disturbances, intraocular inflammation, and retinal detachment. In this video, we demonstrate diverse presentations of a few cases with posterior segment cysticercosis and some practical pearls to manage those situations. Our first case is a 40-year-old female who presented with a large intravitreal cysticercosis extending almost up to posterior lens surface. She was planned for PPV and cyst removal. After making standard scleral ports, a large cyst with live undulating scolex was noted in vitreous cavity. The cyst was rapidly engulfed with cutter within the vitreous cavity. Triamcinolone was injected to ensure complete hyaloid removal. Thick fibrous membrane was noted at the site of cyst, which was gently removed with the help of cutter and ILM forceps. This is important to prevent postoperative pervisual inflammation, ERM formation, and retinal detachment. Peripheral vitrectomy was completed 360 degree and endolaser was performed around the cyst site. Hence, intravitreal cysticercosis can be engulfed in the vitreous cavity by cutter without in toto external cyst removal. Complete removal of all debris and membrane are essential. Our second case is a 50-year-old male who presented with a large submacular cysticercosis. He was planned for PPV. After standard 25-gauge scleral ports and core vitrectomy, posterior hyaloid was removed, ensuring cyst integrity. Any inadvertent subretinal cyst structure may cause intense inflammation. A retinotomy was made on a suitable location. Temporal pars plana approach was considered as it was a very deep-seated eye. A constant but gentle suction was created with a 25-gauge silicone tip to extrude the cyst in toto from subretinal space to the vitreous cavity. It was engulfed with cutter thereafter, followed by fluid air exchange, endolaser, and siliconal tamponade. Hence, 25-gauge silicone tip assisted suction is an effective way to remove subretinal cysticercosis. A retinotomy can be planned in a favorable position. Temporal pars plana approach may be adopted in a deep-seated eye. Our third case is a 23-year-old male who presented with an intravitreal cysticercosis and associated total RD with extensive PVR changes. Following core vitrectomy, intravitreal cysticercosis was engulfed with cutter. Underlying narrow funnel retinal detachment with extensive PVR membranes were noted. After partially dissecting the posterior vitreous membrane, PFCL was injected to flatten the posterior retina. Standard steps of retinal detachment surgery were completed thereafter. Hence, posterior segment cysticercosis with RD and extensive PVR changes has guarded prognosis. However, PPV may be attempted to prevent thigh cysts and achieve ambulatory vision. Fourth case is a 35-year female who presented with a small subretinal cysticercosis in left eye. Cyst enlarged significantly over next 4 weeks. Although advised surgery, she did not consent and was lost to follow-up. Came back after 6 months with leukopodia and a narrow funnel RD on USG. She progressed to panophthalmitis and required evisceration finally. Hence, untreated submacular cysticercosis has a high risk of spontaneous rupture. It may lead to panophthalmitis requiring evisceration. To conclude, PPV is mainstay in managing cases with posterior segment intraocular cysticercosis. Early surgical management is essential to prevent irreversible visual loss. Appropriate preoperative evaluation, use of proper instruments, customized maneuvers, and intraoperative adjuncts in individualized way may help in achieving favorable outcome. Thank you.